We're going to continue now with ear, nose, and throat. And this is, otitis media is like one of the biggest things you'll see in pediatrics. You will get some questions related to it because of complications that can occur. Otitis media is responsible for 30 million visits a year to the doctors. Okay. Any ENTs in here? ENT wannabes? No? Okay. About $2 billion a year in expenditures, and ventilation tubes, or the PE tubes, or the myringotomy tubes, are the most common minor surgical procedures, and tonsillectomy, adenoidectomies, is the most common major surgical procedure in this country. So it's not something you really laugh at because it's huge expenses. A 4-year-old is seen in the office with a 3-day history of fever and cold symptoms. Now complains of right ear pain. Physical examination is remarkable for a bulging tympanic membrane with loss of light reflex and landmarks. Okay? So this is otitis media. These are some of the causes of it. Risk factors of otitis media. Well, infants and children are at highest risk for otitis media. And that's after 6 years of age, it starts to drop. Males are a little slightly higher risk. Daycare puts you at higher risk, probably because you're going to get more upper respiratory infections. Secondhand smoke. So not only is smoking bad for your lungs, how many smokers do we have in the audience here? Nobody wants to admit it, eh? They're pointing at each other, though. You do it, you do it. Okay? So we have probably more smokers than will admit it. So not only are you poisoning your lungs, you're poisoning your kids' lungs, and you're also putting them at higher risk for otitis media. Lots of reasons to quit. Okay? Formula feeding, bottle feeding, predisposes you to otitis media. We talked about breast milk causing, breastfed babies have fewer ear infections and upper respiratory infections. So these are predisposing factors. Smoking, upper respiratory infections, child care, things like that. Craniofacial anatomies. Now, we saw the child with the cleft palate. That predisposes you to recurrent otitis media. Eustachian tube dysfunction. So here we see some of the factors. Eustachian tube dysfunction, allergies, immunologic deficiencies, ciliary dyskinesia, not as common, but it can happen, bacterial infections, and viral infections. Viral infections are much more common than bacterial infections, but you need to know these 3 bugs. Okay? Strep pneumonia, the non-typable H flu, as opposed to H flu type B, okay? And Moraxella, Branamella, Neisseria cataralis. Same bug. All different names, same bug. Okay? So these things in conjunction will lead to otitis media also. The most common bacterial cause is going to be strep pneumonia. And again, 30%. Now remember, the H influenzas, it depends on where you live, but at least a third are beta-lactamase producers. That's probably going up with time. Okay? The Moraxella, whatever, they're all beta-lactamase producers. So you need to know that to know what kind of antibiotics you're going to use. This is just to let you know anatomy portrays a part in causing otitis media. This is the eustachian tubes in an infant or a younger child. You can see one thing, it is going to be a little bit shorter. It's also going to be a little bit narrower, and it's a little bit more horizontal, as opposed to in the adult, it is going to be more, it's sloping more. It's also broader, and it's longer. So it's harder for germs to work their way from here into there. So anatomy plays a big part in children getting more ear infections than adults. The fact that if you have a lot more colds, which children do as they're growing up, causes more congestion and changes in pressures, and again, the pathogens can get into the middle ear a lot easier. What do you find with otitis media? Earache, otalgia. Okay? That is the biggest thing that you will find in a child with otitis media. That's probably the most common presenting complaint, is otalgia or earache. They may have some drainage from the ear. They may have some fever. They may have diarrhea. I don't know the connection, but it happens. And they can have irritability and anorexia. An older child will actually tell you this is the ear that hurts. An infant, smaller child, will grab at that ear. They will bat at that ear. Of course, remember we said that teething can do that too. But teething shouldn't be causing ear drainage, fever, diarrhea, irritability, or anorexia. Okay? This is what you see. Okay? Initially, this is a normal eardrum. Then you get a little bit of fluid behind the ear. And finally, it's like a mini abscess inside this closed space. How do you diagnose otitis media? You look at the ear. You look in the eardrum and you'll see a big red bulging tympanic membrane. Okay? It'll be bulging out towards you. Otoscopy is very good, pneumatic otoscopy. So you blow a little air in there to see if the eardrum moves. It's also good for chronic serous otitis media. So you don't need to run any tests. Okay? They're always asking what's the best test. In this case, the best test is a physical exam. Look at the ears and look at this bulging eardrum and you know you have otitis media. If you have to do something, you do pneumatic otoscopy. Okay? So you remember those words too. And that's when you blow a little air in the ear canal. Treatment is going to consist of antibiotics. Amoxicillin is still the preferred antibiotic for otitis media. Okay? You can use higher dose amoxicillin and it's still the preferred antibiotic. If you have resistance, then you go to your second-line antibiotics, and that includes amoxicillin clavulanic acid plus amoxicillin. So you give them even more amoxicillin, but you give them the clavulanic acid for the beta-lactamase producers. You can use some of the cephalosporins, but amoxicillin is the drug of choice. If the patient is still, it might give you a question where the patient is complaining of, still has fever or earache after 72 hours, then you have to think of beta-lactamase producing organisms and you change your antibiotic. Complications of otitis media. You can have persistent middle ear effusion. That's just a little bit of fluid behind the ear. You don't do anything about it. You don't need to treat them with antihistamines or steroids or decongestions. Leave it alone. It usually goes away in a few months. You can have recurrent otitis media, and you treat them again, and if you have too many recurrences, then you may end up having the myringotomy tubes or the pressure equalizing tubes that you see many times when you look in the ears. Otitis media with effusion, again, it's just persistent fluid but little or no symptoms, usually clearing up within 3 months. The tympanic membrane may be retracted, and when you do pneumatic otoscopy, it doesn't move very well. Hearing loss is the most common complication of otitis media. That's one really good reason to treat it. The eardrum can perforate, and that's when you get the ear drainage, and usually at that it'll heal up on its own. This is mastoiditis. Right here, there's redness, and there's swelling, and it pushes the ear forward, and that is mastoiditis, and that is a complication of otitis media. Cholesteatomas. This is a little pocket of squamous epithelial cells that gets caught in the tympanic membrane, and it can spread and it can actually destroy temporal bone structures, and you need to remove those surgically. Call the ENT. Meningitis is the most common intracranial complication of otitis media. So remember when we talked about CSF findings, and we had those findings, and we talked about a partially treated meningitis? That could be from a patient who was taking oral antibiotics for an otitis media, and it still broke through and caused meningitis. So remember that when you get a question, you got a child that you think has otitis media and now has signs of meningitis. You may not grow anything on your CSF, or your CSF findings may be a little bit different than normal meningitis. And labyrinthitis can result from otitis media, and the symptoms will include vertigo, nystagmus, tinnitus, hearing loss, and vomiting. Okay, so why do we treat them? Because we don't want them to have hearing loss. So we worry about speech and language development, cognition, and school performance. Any child that, let's say your development chapter or whatever, you get a child that, a question, and your child has poor speech or delayed speech, you should do a hearing test as part of your evaluation, because if they can't hear, then maybe they'll have delayed speech because of that. So look in the ears and see if they've had, or get a history of chronic ear infections. That could be why they have hearing problems. Okay? These are the myringotomy tubes, or the pressure equalizing tubes that you get put in for chronic recurrent otitis media. Usually when you start to have hearing loss or things like that, because of recurrent otitis media, you'll end up with these. Okay, this is otitis externa. It's also known as swimmer's ear. How are you going to tell the difference between otitis externa and otitis media? You'll look at the ear. Clinically, there's a little bit of a difference too. Otitis externa is usually caused by repeated wetting of the ear canal or repeated trauma to the ear canal. So that's why they call it swimmer's ear, because the swimmers are in the water all the time, so it's always wet and it breaks down the tissue. Okay? On physical exam, how are you going to tell the difference between otitis externa and otitis media? Before you even look in the ear canal, with otitis externa, when you manipulate the external ear, it hurts. And with otitis media, that's not a problem. It hurts all the time. And when you do this, that doesn't bother them. With otitis externa, you do this, you're manipulating all that skin that's inflamed and all, and that really hurts. When you look in the ear canal, then you will see a very erythematous ear canal. You might be swollen, and sometimes it looks macerated. Kind of like when you put your fingers under water for a long time and they get all wrinkly, you'll see that in the ear canal. So that's how you're going to distinguish one from the other. They both cause earache. So you can't just say, oh, earache, it's otitis media. They both cause earache. This could be an otitis externa. So if you manipulate the outer ear, that's a real good key when you're reading your question. Think of Pseudomonas and Staph as your causes of otitis externa, and you treat them with antibiotic drops. Okay? Also, you teach parents not to put things in their ears, whether they're children or not. The rule of thumb is you don't put anything in your ear that's smaller than your elbow. Okay? So that means you don't put anything in your ear. You don't use swabs to clean out your earwax, because you end up packing it in, or repeated trauma can cause an otitis externa. Just let the earwax come out on its own, or let it stay in there. It doesn't matter. Okay, how about this? Foreign body. Oh, in the loge. In the back. Why is it blue? Because it's a blue foreign body. Oh, was that an interception? No? Did he say that? Did he say foreign body? The guy with the... You didn't? Well, forget it, liar. Okay, that's a foreign body. Now, what kind of foreign body is it?
Hey, it's stuck in my head.
What? Can't hear you. It's an eraser. This is an eraser. This is a Kaplan student that was falling asleep, had his pencil in. I woke him up, and it broke, and that's why I don't wake him up anymore. Okay? No. It is an eraser, though. That's a foreign body in the ear. There's a bug. Oh. And there's a bead. Children will put all kinds of things in their ears, okay? Bugs sometimes crawl in there on their own, and they'll complain of a buzzing sound when they get a foreign body, okay? And the best way to remove a bug? Lidocaine. Lidocaine. No, light if it's a moth. When it's alive, you use lidocaine. And that irritates them and they move, they go out. Okay? But if you put, some people will use mineral oil or stuff like that, and that kills them, and now you still have to dig it out. So you don't want to do that. So you put a little bit of viscous lidocaine in there, and it gets them mad and they come out. Okay? The other thing you need to remember about foreign bodies, if it's a dry vegetable like a piece of corn or a bean, okay, you don't want to flush those out. Because if it doesn't come out, what happens to a wet bean? It germinates. Jack and the Beanstalk coming out of your head. Okay. It swells. Before it germinates, before it grows, it will swell. And that really hurts in the ear. canal, okay? So you don't want to have that doing, so if it's a dry vegetable like that, don't try to flush it out. Okay, the nose, working our way, ear, nose, and then throat, right? Choanal atresia. A newborn is noted to be cyanotic in the well-born nursery. On stimulation, he cries and becomes pink again. The nurse has difficulty passing a catheter through the nose. This is a classic presentation. Okay? So choanal atresia is a septum between the nose and the pharynx. And why does it present at birth? Because babies are obligate nose breathers. And so what happens is they can't breathe through their noses, so they're going to turn blue. And when they get stimulated, they cry, so they will now breathe through their mouth, and they pink up. So the classic presentation, the test question, is usually blue baby pinks up on crying, calms down, gets blue again. Okay? And the rest of the exam is pretty normal. And then you can't pass a catheter through the nose because you've got choanal atresia. There is an association with what's known as the CHARGE syndrome. The C stands for coloboma, the H is for heart disease, the A is for choanal atresia, the R is for retarded growth and development, the G is genital anomalies like hypogonadism, and the E is ear anomalies like deafness. So there is an association with choanal atresia and what's known as CHARGE syndrome, although it can be an isolated finding. What's the diagnostic test? You can't pass the catheter through the nose. Really expensive test, isn't it? Okay, really complicated. So you can't pass the catheter through the nose, then you can actually do fiber optic rhinoscopy and you see the plate there. And the treatment is establish an airway. Always remember airway, breathing, circulation. So you try to establish some kind of an airway so the child can breathe, and then you correct it surgically. Infections of the nose. Upper respiratory infections or common cold. Okay? These are usually caused by rhinoviruses. That's the most common cause. You can have parainfluenza, RSV, coronaviruses, but rhinoviruses are the most common. And if any of you have ever had a cold, then you know the symptoms. Okay? Just think back to that. Children are the major reservoirs. Okay? When our residents and our medical students go through pediatrics, that's when they get sick because they catch everything from the kids. They haven't been exposed to these germs in a long time. So children are the ones that carry the viruses to each other. The incubation period is very short, 2 to 5 days, and it's usually large droplet transmission or small aerosol particles, so it's sneezing and coughing, and you get it on your hands. That's why we always tell everybody to wash your hands before you go to the next patient. So you get the stuff on your hands, on your eyes, you go like that, you're spreading it around, you catch it yourself. The symptoms are going to be fever, nasal congestion, rhinorrhea, and sneezing. Pharyngitis, malaise may be present. It lasts about a week. Okay? If you treat it, it lasts a week. If you don't treat it, it lasts 7 days. Right? What's the difference? None. So you really don't need antihistamines. Do not help. So if they ask you about giving antihistamines to somebody with a cold, they don't help. Decongestants may help, but not antihistamines. Okay, this is sinusitis. Sinusitis is going to be caused by strep pneumonia, by Moraxella, and the non-typable H influenza. Sometimes Staph aureus and anaerobes. So the first three that I mentioned are the same ones that can cause ear infections, right? They can cause sinusitis. Look for purulent nasal drainage and coughing. Also, this is very important. If you're reading a test question and this child has had a cold for more than 10 days, you should start thinking of a sinusitis. Or if the child has been fine, getting better from a cold and now spikes a fever, you should think of sinusitis. Or if the drainage becomes purulent after 7 to 10 days, you should think of sinusitis when you're reading your question. Older children and adolescents will complain of the headaches. On exam, they can have tenderness to palpation of the frontal sinuses or the maxillary sinus and things like that. Little children won't. First of all, their sinuses aren't that well developed, and they can't complain as much. They just complain about everything. Okay? It's a clinical diagnosis, but you can get x-rays in older children who have developed sinuses, and you will see air fluid levels like, well, here's some stuff. Here's a good air fluid level. See it right there? There's air and there's fluid. This one's just completely opacified. Okay? Really opacified. So look for, you can get sinus films, although usually it's a clinical diagnosis. You can, a really expensive way, so if they ask you what's the most expensive way to diagnose sinusitis, okay, you can say a CT scan. Okay? But you don't want to do that. That's not your first choice. If you suspect sinusitis and they ask you for a test and the child is old enough, let's say he's like 8, 9, 10, 11, then you can get sinus films. If they're 3 years old, you're wasting your time on sinus films. Okay? The treatment consists of antibiotics. You can treat anywhere from 14 to 21 days. Sometimes you need to treat 21 days simply because it's harder for the antibiotic to penetrate into those areas. Complications include, well, we talked about orbital cellulitis earlier today, so that's one of the complications. You can also form abscesses or you can get a meningitis from sinusitis. Epistaxis. The 10 most common, Dave Letterman's top 10 list, right? Top 10 reasons for getting epistaxis. Reason number 1, reason number 2, reason number 3, 4, 5, yeah. They're at your fingertips, okay? So whatever finger you want to use, that's a common reason for nosebleeds, okay? The majority of nosebleeds occur because you pick your nose or repeated trauma to the nose. So patients who have allergic rhinitis, seasonal allergic rhinitis, doing that all the time, then they can have they can have epistaxis too. So an 8-year-old has repeated episodes of nosebleeds, past history, family history, and physical exam are unremarkable. Well, usually that's the case. So the most common cause is picking your nose. Trauma, foreign bodies, and inflammation, such as recurrent URIs, allergic rhinitis, can also cause nosebleeds. And very rarely will you have vascular anomalies or coagulation problems, things like that. Epistaxis is rare outside of childhood, unless you pick your nose a lot as an adult, I guess. Okay? You can have an angiofibroma, should be considered in pubertal boys with profuse bleeding and an associated nasal mass. So sometimes you do need to look up the nose and see if there's anything up there. Foreign bodies can cause nosebleeds, but usually the story for foreign bodies is going to be what? Purulent, unilateral nasal discharge. Okay, so the child, here's let's say a 3-year-old is seen in the office because of foul-smelling, purulent, unilateral nasal discharge. Patient had a strep screen done in the emergency department the night before, which was negative because he complained of some sore throat. On physical exam, when you walk into the room, it smells like somebody's died in there. Okay? And when you examine the child, there's nothing wrong with the ears, the throat looks okay, but you look up his nose because you know that it's coming out one side, and lo and behold, what is there? Piece of foam that he had, from a cushion that he had jammed up his nose, had been there for who knows how long. Okay? So purulent, unilateral nasal discharge is going to be very suspicious for a foreign body in the nose. Nosebleeds usually occur without any warning. Usually they're from just one side. And they can recur, so the parents might say he had 4 nosebleeds last night. Well, what happens is the nose bleeds, it stops bleeding, it forms a little scab, and the child does this because it bothers him, or he picks at it, and you bleed again. Okay? So that's very typical. Most nosebleeds will resolve spontaneously. You can compress, just put some pressure up here. You don't want them like this and like that so the blood goes down this way. You want them like that. Okay? And you may use local vasoconstrictor sprays. Severe bleeds, you can use nasal packing. Sometimes they will actually put this epinephrine in the nasal packing, a vasoconstrictor or something, and then jam it up there. Okay, pharyngitis. This is a biggie. We talked about scarlet fever earlier, and we talked a little corollary of it is pharyngitis. An 8-year-old girl complains of acute sore throat of 2 days' duration, accompanied by fever and mild abdominal pain. Physical exam reveals enlarged erythematous tonsils with exudate and enlarged, slightly tender cervical lymph nodes. So, what's your diagnosis? pharyngitis? Is it strep throat? You don't know. How come you don't know? People can just sit there and say, oh, that's strep throat, I'm going to treat it. Haven't done any tests. Well, that's a defective one. That felt funny. Did that happen? You put it in your mouth? Well, that means it didn't have any paper on it when I threw it at you. You don't care where it's been. Yeah. Oh, put his eye out. Okay, so he's right. You haven't done any tests. You cannot tell the difference. The two most common causes of pharyngitis are going to be virus, or it's going to be group A beta hemolytic strep. Those are the two biggies, okay? And you can't tell the difference just by looking in the throat, okay? If you can, there's some swampland in Florida I'd like to sell you, okay? You have to do a test. The gold standard is throat culture. The gold standard for strep pharyngitis is the throat culture. You may do the rapid test, but any rapid test that's negative needs to be backed up with a culture. Okay? So, pharyngitis is just a generic term for inflammation of the throat. Usually it's acute. And it's rare under 1 year of age. Many times it's because children can't really complain if their throat hurts. But I have seen children with strep pharyngitis that young. But it's very rare. And the most common bacterial cause is going to be group A beta hemolytic strep. It's more common, so when you're reading the question, if you're going to be suspicious for strep, go by the age group. 5 to 10, 5 to 15 years of age. Under 5 years of age, it can happen, but it's rare that it's going to be group A beta hemolytic strep. Under 5 years of age, think of viruses. Okay? And actually, the majority of cases are going to be viral, even in any age group. But when you're reading the question and you're going to be suspicious for group A strep, think of 5 to 10 years of age, 5 to 15. They are often difficult to differentiate clinically. However, they both have erythema, exudates, petechia, and large tonsils. Cervical adenopathies may be common to both. When you're thinking of a viral pharyngitis, and again, you're not going to bet the farm on it, but think of gradual onset, usually preceded by cold symptoms. Okay? If you have vesicles and ulcers in the mouth or the throat, you can be a little bit more confident in saying that it's probably viral. Okay? If they have conjunctivitis, you can say, this is probably an adenovirus. We talked about that earlier. If they have rashes, it depends on the rash, because group A strep can cause rashes too. Okay? So group A strep, they may have more headache, they may have more abdominal pain because of a mesenteric lymphadenitis, and they usually don't have upper respiratory infection symptoms, and it's much more acute in nature. Palatal petechia, you can see them actually in both, but it's much more suggestive of strep. And you can have that sandpapery rash that we talked about earlier today with strep. So let's look at some things. Okay, viral infections are responsible for the majority of pharyngitis. Most viral pharyngitis is after a cold or a flu, and these will get better on their own. Always worry about group A beta hemolytic strep. And again, the age range. Okay, so there's the palatal petechia, and it's a very red pharynx. The uvula is red and kind of swollen, and the tonsils are swollen. Is that strep or is that a virus? No, you don't know. That might help you, but you just can't look at it and say it's strep. What's the best test? Culture it. Okay? You can't just look at it and say it's strep. Look at those. Those are called kissing tonsils. See how close they are to each other? That's how big they are. Those are grade 4 or 4+ tonsils. Strep is it strep or virus? Don't know. Good. Fast learners. Okay, this is the rash, convict, right? This is the rash that you'll see with strep. Remember when we talked about scarlet fever? They have a little bit of circumoral pallor, and then they have this erythematous fine. It blanches if you press it. it turns white and it fills up again, and it feels like sandpaper. But they have this circumoral pallor where they don't have that rash. It's kind of just pale. Usually strep. The white strawberry tongue. We talked about that with scarlet fever. The rash here, again, it's all over, and it feels, yeah, this is really smooth. This is a nice one. So it's a sandpapery rash, okay? Strep, probably. Okay. Most people nowadays do the quick strep test, but you should always back it up. If it's negative, back it up with the throat culture. So that's still the best test is a throat culture. It's the third time I say it. Okay. How do you treat viral pharyngitis? Treat the symptoms. Let them have throat lozenges or gargles, whatever you want, okay? Streptococcal pharyngitis, the drug of choice is penicillin. Okay, if you're penicillin allergic, then you can use erythromycin or the cephalosporins. Okay? And these are the complications of strep. Rheumatic fever, you can have glomerulonephritis, bacteremia, or peritonsillar abscesses. These are all complications of strep pharyngitis. This is a peritonsillar abscess. I'm sorry, this is a retropharyngeal abscess. Okay? That's a retropharyngeal abscess. What you need to look for, this is caused by group A beta hemolytic strep. These patients, they can have airway obstruction, they have drooling, respiratory distress, and the treatment is going to be airway, okay, and antibiotics and drainage. Peritonsillar abscesses, I don't have it, I'm sorry. Peritonsillar abscess, the tonsil is going to be enlarged and it will be pushing the uvula away from the affected side. So remember that. And what you need to remember with peritonsillar abscess when you're reading your test question is hot potato voice. Okay? So we did pertussis. You've got to get all kinds of audio daily doubles here, right? The hot potato voice. That's what they sound like. Because it's go home and put a hot potato in your mouth. And that's what they sound like with the peritonsillar abscess. And the treatment is IV antibiotics and drainage of the abscess. Usually it's like a teaspoon, but that's enough to cause that much. A teaspoon in that little area can cause problems. Okay? This is a cervical lymphadenitis. And anything that can cause we talked about cat scratch causing a lymph node to be big, right? So that's a cervical lymphadenitis. Any condition that causes inflammation and enlargement of the cervical lymph nodes is cervical lymphadenitis. And patients can have fever, swollen cervical lymph nodes, and sometimes torticollis. In children, when you're reading a question and the question talks about a cervical lymph node that's enlarged, or several of them, you should be thinking of infections. Okay. In adults, you might think about neoplasms, right? But in children in particular, think of infections first. So we have TB, we have atypical mycobacterium, we have group A beta hemolytic strep, we have viruses, we have an infected branchial cleft cyst or something, but think of infections first. It could just be a cold. Think of infections first. Then you can think of all these other things, like really bad things like neoplasms. Okay, here's part of the differential diagnosis. This is an infected branchial cleft cyst. That's part of your differential diagnosis. This is a cystic hygroma. Okay, thyroglossal duct cyst can also present as cervical lymphadenitis. Okay. All right. And then last but not least, under ENT is indications for tonsillectomy, adenoidectomy, and you have a whole list of them there. Tonsillectomy, when do you take the tonsils out? If you have persistent oral obstruction. For recurrent peritonsillar abscesses, just take the tonsils out. Hopefully that'll take care of the problem. Recurrent cervical adenitis and suspected tonsillar tumor. When you take the adenoids out, just the adenoids, indications include persistent nasal obstruction and mouth breathing, snoring and snorting, hyponasal speech, repeated or chronic otitis media. When you take both of them out, Well, you can have cor pulmonale from persistent hypoxia because your upper airway is so, because the tonsils and adenoids is so obstructed, you can have chronic hypoxia and you can have cor pulmonale. You should take them both out. Or sleep apnea. Many times it's the child that's okay, they're having sleep apneas. You should take them out. Make that upper airway a little bit bigger. Okay? Or recurrent aspiration pneumonias. Invalid reasons. Just because you had a lot of colds doesn't mean that you have your tonsils and or adenoids taken out. Or recurrent strep. The general recommendation is if you have greater than 7 infections a year, or greater than 5 a year for 2 years, or 3 per year for 3 years, then you should probably take them out. So that's an indication. An invalid reason is the parents want them out, or the ENT needs to make a car payment. Okay? You don't want to take them out just to make some money. A toddler presents to the emergency care center after choking on some coins. Whew. The child's mother believes that she swallowed a quarter. On physical exam, the patient is noted to be drooling and in moderate respiratory distress. There are decreased breath sounds on the right with intercostal retractions. So what is your diagnosis? Yeah, there it is at the top of the chapter. I'm not giving you chocolate for that. It's on the paper. It's a foreign body aspiration. Okay? What is the best way to diagnose this? Bronchoscopy. Okay? X-ray makes you suspicious. Bronchoscopy, you see it and you remove it. Okay? So while you're there, now you'll be suspicious for it because you may not see an aspirated foreign body because it may not be radio opaque on X-ray. But if you, there it is, and you take it out. This is a piece of a carrot. Okay, remember, what's the most common side? The right main stem. Okay, right main stem. So this is a piece of carrot in the airway. Foreign bodies, all kinds of stuff. Okay, the most commonly aspirated foreign body, aspirated, is a peanut. The most commonly ingested foreign body, coin. There you go. Here, finally. You kept saying coin and coin and coin, but now, it's okay. She'll get it. The ophthalmologist will get it for you. Oh, she's going to keep it, though. Okay. So the most commonly aspirated is going to be the peanut, and a coin is most commonly ingested. And ingested foreign bodies can also cause respiratory problems. Right? When you're reading the test question, look for aspirated foreign body, it's a sudden event. Usually it's a witnessed event. I saw Billy taking some peanuts or some candy off the table or popcorn or whatever, and then he choked and coughed and he gagged. So it's usually a witnessed event. Okay? Children less than 4 are really at risk for foreign body aspiration because their trachea is a little bit smaller and because they put things in their mouths. And you shouldn't have children eating peanuts until they're over 5 years of age. You want to avoid, like at 1 year of age, when you start giving children table foods and stuff, avoid peanuts, avoid grapes, avoid like M&Ms and things like that. You want to give them hot dogs. You've got to chop it up and make them rough textured. That way it's harder for them to aspirate. At under 4 years of age, children put things in their mouths. They can easily aspirate. So look for a witnessed event, sudden onset. On physical exam, they can have respiratory problems. They may have some wheezing. They may have some decreased breath sounds on one side versus the other. Okay? So there you have the larynx is the most common site for a foreign body if he's less than 1 year of age. The trachea and bronchi are the most common sites for foreign body aspirations older than a year, particularly the right main stem. They may have stridor if it's higher up in the larynx, for example. The patient with a foreign body in the airway may have localized wheezing or stridor, or actually even bloody sputum. and you may have unilateral absence of breath sounds or decreased breath sounds. I remember a child that was brought in, a 1-year-old, for a suspected apneic episode. Just stop breathing. Well, now the child is examined and you hear decreased breath sounds on one side. Go back and get a little bit more history. The babysitter had been given her popcorn. Taken down to the OR, pulled out a kernel. Okay? You can have non-obstructing foreign bodies, which may not cause a lot of symptoms, and they've been having them for a little bit of time there, but that's rare. Okay, you can take films. Inspiratory and expiratory films are very helpful, but you have to have a child that can take a breath, hold it, and stuff. Okay? So on inspiratory, expiratory films, what you will be looking for is signs of hyperinflation. In this particular case, here's an inspiratory film, and now the patient's breathing out. Look, they're hyperinflated on this side. Why? Because the foreign body is on this side. It's acting like a ball valve obstruction, and air can't get out, so you stay hyperinflated. The other thing you can do is put the child on their side, the side that you suspect has the foreign body, and you do decubitus films, inspiratory and expiratory. And what happens when you're laying down and you breathe out, your mediastinum should shift downward a little bit because it's heavy and gravity's doing its work. But if you have a foreign body, the air is holding up the mediastinum, you don't get that shift. Okay? So again, those lateral decubitus films are nice, inspiratory, expiratory, but only if you have a child that can cooperate and take those breaths. So the best thing to do is bronchum if you really truly suspect a foreign body. So there it is. Oh, visualization with a rigid bronchoscope is a definitive diagnosis. Okay? Now this is a child that has an ingested foreign body. That's part of your differential, because sometimes foreign body ingestions can mimic them. Especially if they've been there for a while, they can still obstruct the airway. All right? So, how do I know? Do you see the foreign body? Right there. Okay? And there it is a little bit later. It's working its way down, and pretty soon it'll be down here, hopefully. How do I know it's in the esophagus? Take a lateral. No. Huh? You follow it. Yeah, but what if it's in the airway? You're going to get it out. You're not going to wait. It's what? The coin shape. What do you mean by that? Very good. Ready? For the laughing couple over there. They're having a good old time today, I'm telling you. They just sit there. Okay, so it's called en face. So if you swallowed it, it's going to be like that. If you aspirated it, it'll be like that. Now, why is that? A little follow-up question. No, not the vocal cords. Cricoid ring? Yes! Okay. This side's starting to do better now. Okay? All right. What happens is your trachea is, the trachea has pretty much, the tracheal rings are cartilage, pretty much three-sided, right? So it's easier for that thing to accommodate itself like that, because you have the back part is soft, whereas the esophagus is soft all the way around, so it kind of like fits in there better. Okay, so if it's in the esophagus, it'll look just like that. If it's in the trachea, it'll be on edge. All right? And that's how you tell the difference on an X-ray. Why is that? Why does the trachea have just the cartilage rings are only three sides until it gets down lower to the carina and it becomes like that? Why is that? Another one. This guy is on fire. Okay? Because when you swallow, if it was solid all the way around, every time you swallowed, the esophagus, that food bolus, that peristaltic wave would boom, bang into the trachea. This way the trachea just kind of gives a little bit. Okay? I think you're the first person in 10 years that I've been teaching this. Here, you get 2 more. Because you couldn't find that one. He needs a, oh, I need to, there. He's the first person in like 10 years I've been teaching that gets this right, okay? Very good for you. Should film him, okay? All right. That's why the esophagus is the way it is. That's why the trachea is the way it is. That's how you're going to tell the difference on X-ray, okay? Versus stomach, esophagus versus airway. Lost my spot here. Where am I? Diagnostic test. Treatment, remove it. The treatment of a foreign body, aspiration is to remove it. Complications, you can have aspiration pneumonias. Foreign bodies need to be removed. This is a bit of an emergency, I'd say, because it's blocking your airway. Okay? And usually the patient does just great once it's taken out. Okay, anticipatory guidance is very important for prevention of foreign body aspiration. So again, hot dogs, peanuts, grapes, popcorn, peanut butter, that kind of stuff you should not be given to children, to young children. Your differential, well, sometimes they wheeze, and sometimes you have referred breath sounds in children, so you think maybe it's asthma. Okay? But a beta agonist is not going to help this child. Okay? Could be a pneumonia as part of your differential also, or an ingested foreign body. Okay, this is a 12-month-old child is brought to your office because of a barky cough. The mother states that over the past 3 days, the child has developed a runny nose, fever, and a cough. The symptoms are getting worse, and the child seems to have difficulty breathing. He sounds like a seal when he coughs. Okay, another audio. This is a lot easier to do than pertussis. The croup cough. Okay, so you have a barky cough, some inspiratory stridor possibly. Okay? Laryngotracheobronchitis. So croup is a garbage can term, and it means that you have inflammation anywhere. It can be laryngitis, it can be tracheobronchitis, laryngotracheobronchitis. It just depends on a different anatomical spot. It's caused by viruses. The most common virus to cause croup is parainfluenza virus. RSV is a second, respiratory syncytial virus. Okay? But other viruses can cause croup too. Measles, for one. And many times you'll have a history of other family members having colds when this child shows up. Usually the age range, you need to know the age range. That's important. Okay? About 3 to 4 months of age up to 5 to 6 years of age. Typically it'll be a 6-month-old to a couple of years of age. You need to know that because there's an overlap between croup and epiglottitis. It presents one of two ways. Generally, it's a child who's had a cold for a couple of days and then develops the barking cough or the hoarseness and the stridor. Or it's a child that the parents put to bed, doing fine, and all of a sudden they're waking up with this horrendous sound of the baby coughing with that bark and maybe some stridor. And they get real nervous because he's breathing, working hard to breathe. So those are the two typical presentations of croup. On exam, they may have some fever, the barking cough, and the stridor. They may have some tugging, tracheal tugging, for example. They may have nasal flaring because the obstruction is getting worse. So they will have signs of respiratory distress. Most patients will exhibit the symptoms of stridor and slight dyspnea before they start to get better eventually. Okay? Very rarely will they have like hypoxia and tachycardia and things like that, but that can happen, and it can be a serious disease. But generally, it's not too bad a problem. Really, you don't need to do any diagnostic tests as far as, you can do an MP wash and stuff, but the best thing to do is get a neck film. Okay, a neck film, and because you want to distinguish between epiglottitis and croup, so you get a neck film, and you'll see what's known as the steeple sign. Okay, so there, it's called the steeple sign because it looks like a church steeple. Some people call it the pencil sign. I always say alcoholic radiologists call it the wine bottle sign. Okay. Again, it doesn't show up as well, but the lungs are very clear. And it kind of narrows right there. Okay? And I think the next one, nope, that's not good. Okay? All right, so that's croup. You will get a PA and lateral of the neck and look for the steeple sign. The lateral is to look for the epiglottis. The treatment of croup. Usually you can manage this at home. And what you do is try to keep the child calm, mist or moisture, so you can go like into the bathroom and run hot water and get like a steam bath going, and that really helps. Cool air helps. Typically, it happens in the middle of the night. Typically, it happens around winter time, and you're driving in, and by the time you get in, the patient sounds better because of the cool night air has helped. So those things help. Humidification or cold air can help. A racemic epinephrine treatment will help. So in the hospital, as far as medications, racemic epinephrine, aerosolized epinephrine helps because of the vasoconstrictor effects. However, you have to worry about rebound edema when it wears off. Corticosteroids intramuscularly have been shown to help with croup. It is a self-limited disease, so for the most part, these patients will get better on their own. Antibiotics will not help with croup. Okay? Complications include middle ear and lung infections from the virus. Also, a bacterial tracheitis, and that's what you have here. See all that stuff? That's pus. Bacterial tracheitis needs to be considered as a complication of croup sometimes. Okay? The differential, well, we have spasmodic croup, and that's the one that the patient just starts out of nowhere. Okay, there's usually no history of infection, and they start with that spasmodic cough, and that goes a lot of times with allergic children. And part of the differential is bacterial tracheitis, and you always have to worry with bacterial tracheitis about staph. So cover staph as part of your antibiotic coverage. Diphtheria. They may have a serous nasal discharge, and if you're going to diagnose diphtheria, look for the gray-white pharyngeal membrane. Okay? So you look in the throat, and you'll see that membrane. You also have to worry about epiglottitis. Again, epiglottitis, we see less of it now because of immunizations, but you still need to keep that in mind. So that's your differential diagnosis. A 2-year-old child presents to the emergency center with her parents because of high fever and difficulty swallowing. The parents state that the child had been in her usual state of health but awoke with a fever of 104, a hoarse voice, and difficulty swallowing. On examination, the patient is sitting in a tripod position. That means the patient is leaning forward with his neck extended, trying to straighten out the airway so that you get better airflow in. The child is drooling, has expiratory stridor, nasal flaring, and retractions of the suprasternal notch and supraclavicular and intercostal spaces. So epiglottitis is inflammation of the epiglottis, and it will cause airway obstruction, and it is an airway emergency. A little bit of a difference between epiglottitis and croup. First of all, children with epiglottitis look a lot sicker. They're generally a little bit older. So this one is 2 years old, but it could be a 3 or 4-year-old because the range is up to about 6 years of age, actually. They look sicker. They don't have as much stridor or barky cough, but they do have more drooling, and that neck, the head is hyperextended. So they have a little bit more air, a lot more air hunger, and not as much of a cough, and they tend to have higher fever. So look at those things when you're differentiating croup and epiglottitis. Okay? It's generally caused by H. influenza type B. That's the most common pathogen. The incidence of epiglottitis is decreasing because we immunize patients. So you might want to look for a history of immunizations in the test question too. Usually there's nobody else ill in the household, as opposed to croup where other kids are sick or other family members have colds. Look for sudden onset of high fever, the dysphagia, drooling, and a muffled voice. And the tripod position is like a giveaway. The patient on physical exam has a lot of respiratory distress, and they have a lot of air hunger, which, if you're not careful, they'll die. This is an airway emergency. This is not the child that you want to say, all right, let's go get an x-ray, and you send them off on their own. You know, go down the hall and make a left, and then your third right, there's x-ray, because their airway could close off by the time they're getting their x-ray. This is the patient you don't want to struggle with to lay down to look at the throat, because the airway will close off while you're examining them. Okay? If you can get a lateral of the neck, and what you'll see here, did you remember when we showed the retropharyngeal abscess? There was a lot of swelling. So let me just show you what a normal lateral of the neck looks like as far as soft tissues. When you look at the lateral of the neck, the soft tissue structures should never be any bigger than your vertebral body, any wider than a vertebral body. Now, that other picture that we showed you came all the way out to here. Okay? So it should never be any bigger than your vertebral body. This is pretty normal. Now, where do we find the epiglottis? Look for the hyoid bone right here, and right here is the epiglottis. So look right there, and this one's thick. That's what's called the thumbprint sign. Sounds important. It is. That's the thumbprint sign for epiglottitis. And that's what the epiglottis looks like when you're trying to intubate a patient. You're going to use a much smaller tube. That's why you don't want to fight the patient. So I want to see that cherry red epiglottis that Dr. Pino talked about, okay? Because it's called the cherry red epiglottis. Well, you do that, the airway could close off. So it's an airway emergency. The first thing you have to do, the next best step, okay? If you're thinking this patient has epiglottitis, the next best step is secure an airway. Once the airway is secure, that patient's cured because you can just give them antibiotics and they'll get better. So the next best step is an airway. Okay, here's another one. Here's the hyoid bone right here. You draw a line straight back, up, and it looks like a thumb. It should be a little flap that just goes like that. It's a thumb. So that's the thumbprint sign, and this is also normal. Okay, so that's how epiglottitis looks on the lateral. Once again. Okay. Okay, the diagnosis is made on clinical and physical findings as well as visualization of the enlarged epiglottis. That's as you're intubating the patient, okay? By experts in endotracheal intubations and tracheostomies. The airway is usually obtained in the operating room under controlled conditions if you can. That's the best thing to do. Sometimes you don't have time for that. And the lateral of the neck will show the thumbprint sign. The airway should be secured. This is really important. Imagine treatment. The first thing they mention in treatment, an airway should be secured regardless of the degree of respiratory distress because it could swell up later. So you should have somebody who is very good at intubating and someone who knows how to do a tracheostomy if they can't get the intubation. Okay, but the best thing is to take them to the OR and do it. But if you don't have time, you don't have time. That's the first thing you do is intubate them. After that, you can get blood cultures and start antibiotics. You can actually culture the epiglottis too. You can get a little swab of it. And third generation cephalosporins are probably the first choice. And then you intubate the patient. You keep the patient intubated for a couple of days. Let this stuff kind of shrink down. You can look again and see there's probably a leak around the tube, and you can extubate the patient, usually at 48 to 72 hours after starting antibiotics. Complications, well, a tongue blade should never be used to examine the pharynx in a patient with suspected epiglottitis because they will have a laryngospasm, the airway will close off, and they can die. Okay? So that's the major complication is death from airway, loss of the airway. Okay? And your differential is croup. Again, go by how sick they look, by the age. And a lot of times, that cough. Foreign bodies can cause sudden onset of respiratory distress, so that's part of your differential. Abscesses, peritonsillar and retropharyngeal abscesses can also cause airway problems. They can have high fevers. They will have the sore throats, so that's part of your differential. Okay, let's talk a little bit about asthma now. That's not it, okay? A 6-year-old boy presents to his physician with end expiratory wheezing scattered throughout the lung fields. He is noted to have nasal flaring, tachypnea, and intercostal retraction. So these are signs of? No, they're signs of respiratory distress. Okay, there's a lot of things that can cause this, not necessarily asthma. These symptoms are triggered by changes in the weather. He has a family history of asthma and atopic dermatitis. He has never been intubated or admitted to the pediatric ICU. Good for him. His last hospitalization for asthma was 6 months ago. He takes medicine for asthma only when he starts to wheeze. Reversible obstructive airway disease. So remember that. Symptoms come and go with asthma. And it affects both small and large airways. And you're due for another audio daily double, right? Wheezing. That one's easy, okay? So the wheezing occurs, or this obstruction occurs in different sized airways, and if you think of your airways as like a pipe organ, because there's different sizes, you will actually hear different pitches of wheezing. There's three components of asthma. Number one is the bronchospasm, where the muscles actually constrict, mucus production, and airway edema, and medications help with all of these. The obstruction caused during an asthma attack will cause an increase in your airway resistance and decrease your forced expiratory volumes and flow rates. And you can actually measure, like FEV, forced expiratory volumes and rates in 1 second or whatever. You can measure those. In addition, the lungs will be hyperinflated, and there's premature airway closure, so there's air trapping. So we're all going to feel like an asthmatic. Anybody here have asthma? Nobody? Not one of you has asthma or had asthma growing up? Yeah. Had. Okay. Gosh, you got a pretty healthy bunch. Nobody smokes, just point to each other. But you don't wear helmets and you don't wear seat belts. I remember that. Okay, let's feel like an asthmatic. Take a deep breath. Let out just half of that breath. Take another deep breath. Let out half of that breath. Take another deep breath. None of you can go on? Okay? All right, that's what an asthmatic feels like during their attack. Everybody take regular breaths now. Let them all out. Okay? Everybody, that's what an asthmatic feels like because they have air trapping. Because of the bronchoconstriction, the edema, the junk in the airway, and the premature airway closure, you can't get the air out, so you can't take the next breath in. And that's why they feel really, really tight. And that's why on X-ray many times you will see hyperinflation. Okay? So that's exactly what an asthmatic feels like during their attack. You can let go whenever you want. They can't. Okay? Etiology is unknown, but it does run in families. It can be related to the environment, or it could be a combination of both. There are a lot of factors involved, such as immunologic, endocrinologic, endocrine, infectious, a lot of different things. Nobody has their finger on asthma yet. And the presentation varies. You can have acute attacks after an exposure to something, or it can be an insidious attack occurring over several hours to a couple of days. It can be triggered by lots of different things. They will have a very tight, non-productive cough. Many people call it a bronchospastic cough. Wheezing is the hallmark of asthma, but not everybody that has asthma wheezes, and not everybody that wheezes has asthma. So remember that. Some patients with asthma just have a persistent cough, worse at night, like that. Worse at night. Some people will have a cough or difficulty breathing when they exercise, or in cold weather, or after they catch a cold, or after they've been exposed to smoke, or to the cat, or to the dog, or to cutting the grass. There's lots of different triggers, and it presents lots of different ways. So remember wheezing, dyspnea, and a prolonged expiratory phase. When I did my wheezing just now, I prolonged my expiratory phase. And that's what patients do. Without even thinking about it, they want to get air out so they can take that next breath. They need to make room for the next breath. So that's why they have a prolonged expiratory phase. And you will see symptoms of respiratory distress, accessory muscle use, intercostal retractions. Sometimes they'll have nasal flaring. Okay? They can complain of abdominal pain. Why? Because they're using every muscle possible, including abdominal muscles, and that hurts. That's like doing lots and lots of sit-ups. The liver and spleen on physical exam may be palpable. That doesn't mean that the liver and spleen are big, however. That just means it's being pushed down by the diaphragm because of the hyperinflation. On X-ray, you can actually sometimes see a somewhat flattened diaphragm. Clubbing is not a hallmark of asthma because it's reversible, and so they oxygenate well in between attacks. You won't see clubbing. There is no one diagnostic test for asthma. Usually it's a clinical diagnosis, a family history of asthma, The patient has recurrent episodes of wheezing with exposure to whatever, okay? Whatever triggers there are. Physical exam during an episode or of severe symptoms can be helpful. Again, there's not one test you can do. You can see eosinophilia in a peripheral smear. We talked about the mnemonic, right? Sputum will have eosinophilia also, and it's this thick, really tenacious, rubbery sputum. Allergy skin testing can help. Exercise testing in older children, you put them on a treadmill, for example, and you get them running and you can trigger an asthma attack. Response to bronchodilators helps, but there is no one test. Okay? Pulmonary function test before and after bronchodilators in older children is helpful. Again, that's not pathognomonic. X-rays. X-rays will show hyperinflation. X-rays will show, like I said, the flattened diaphragm. The ribs will be more horizontal and maybe a little farther apart. You can sometimes see atelectasis, particularly right middle lobe atelectasis. You can see perihilar inflammation with asthma. And you take X-rays to make sure that there's not a mass or a pneumonia or anything else that's part of your differential diagnosis. You don't need to get a chest X-ray on a patient every time they have an asthma exacerbation. But particularly at the first time you might want to, because it could be a mass. Or if they have fever, you want to rule out pneumonias or atelectasis. Blood gases. Blood gases are not done routinely on asthma patients. However, sicker patients do get blood gases. And you can see a pattern in the blood gases. And this might show up on a test question. Okay? So you need to know that initially, patients are kind of hyperventilating. So your blood gas will show that your PCO2 may be on the low normal side. As your attack progresses, you will have a PCO2 starting to rise, and then finally, at the late stage, when the patient is really tired and things are looking bad, the pH starts to drop because you've used up all your buffers, and now your pH starts to drop. So you can follow the progression of an attack by looking at those blood gases. It doesn't mean you do them all the time, but if they're that sick, you probably do. And that would be a nice little question to see where you are in your stages of asthma. The best treatment is avoiding the triggers, but not everybody knows what their triggers are all the time, and you can't avoid some of the triggers. Daily management of the asthmatic varies. Asthma is divided into these following categories now. These are the new classifications, what we call mild intermittent, mild persistent, moderate persistent, and severe persistent. And depending on where you fall, depends on how you get managed. The acute attack, the acute attack of asthma will be managed with bronchodilators, usually the beta agonists, the beta 2 agonists, oxygen, steroids. Okay? Those are the big three that you're going to use for the treatment of an acute exacerbation of asthma. Mild intermittent asthma, by definition, the symptoms occur more than twice each week. Nocturnal symptoms, that's like the coughing, not necessarily wheezing, but coughing too. And these patients don't need daily medication. It is recommended that you use short-acting inhaled beta-2 agonists when you have symptoms. So just when you have the symptoms. Mild persistent means that the symptoms occur more than twice a week. Mild intermittent, less than twice each week it should be. Okay? The mild intermittent, change that to less than twice a week. Mild persistent, more than twice a week. Nocturnal symptoms, more than twice a month. And you need daily medications. And the maintenance medications will be cromolyn, the mast cell stabilizer, nadocrimil, or an inhaled corticosteroid. And more in children, you use inhaled corticosteroids as the drug of choice for maintenance therapy of mild persistent asthma. Okay? And then when they break through, you add the beta-2 agonist. Moderate persistent means that you're going to have more frequent symptoms and wheezing between the severe exacerbations. So you're going to use the inhaled corticosteroids. You're going to use the long-acting beta agonists, and then you add the short-acting when they break through. And severe persistent, these are daily symptoms, and you're going to get into the hospital more often, and you're going to use inhaled steroids again, plus the long-acting beta agonists and short-acting beta agonists when you're more symptomatic. Nowadays, one of the other drugs that we can add is the leukotriene receptor antagonists. Okay? And those have to be taken all the time also. That's a maintenance medication. You don't take it just when you break through. You're taking that as a maintenance medication. So the leukotriene receptor antagonists. Exercise-induced asthma. How do you treat that? You use beta agonists prior to exercising. Okay? So it's a little bit different in adults, isn't it? Okay, complications of asthma. You can develop pneumothorax, obviously the respiratory distress, the forceful coughing, the mucus plugging. It is rare, but it can happen. You can die from asthma. You know, in the last 5 or 6 years, people have been talking about people dying from asthma. It's basically because they haven't been managed properly. It's not the medications that are causing it. It's that they just haven't been managed properly. And many times, particularly patients who have had asthma for quite some time, they think that they can manage it at home on their own, and they come in really, really sick because, oh, it's another attack, I'll get through it. They come in really, really sick, and they can die. So there is an increase in mortality. Okay, remember that all that wheezes isn't asthma. There are other things that can cause you to wheeze, like a foreign body, like Leffler syndrome, like cystic fibrosis, like bronchiolitis. So you need to remember those things as far as your diagnosis. Okay. A 6-month-old presents to the physician with a 3-day history of upper respiratory tract infection, wheezy cough, and dyspnea. On physical exam, the patient has a temperature of 39 degrees centigrade, breathing 60 times a minute, nasal flaring, accessory muscles. A patient appears to be air hungry, and the oxygen saturation is 92%. Okay? So, bronchiolitis. Bronchiolitis is caused most commonly by respiratory syncytial virus. It is going to be in children under 2 years of age. So when you're reading the test question, that's an important pickup. Less than 2 years of age, bronchiolitis. And they will have usually upper respiratory symptoms prior to developing the coughing and the wheezing. Okay? Bronchiolitis is not really a bronchoconstrictive disease. It's more of an inflammatory disease with a lot of junk. But since these children under 2 years of age have narrower airways, there's an increase in airway resistance, and they can get into a lot of trouble with lower respiratory tract infections. Other viruses causing bronchiolitis include parainfluenza, mycoplasma, adenovirus, and obviously secondhand smoke predisposes you to have upper respiratory tract infections and also to get bronchiolitis. Look for a history of upper respiratory tract infection, and then they develop higher fevers and develop respiratory distress and what they call a rattling cough. And on exam, they will have rapid breathing. They can have wheezing and rales, and they can have all the signs of respiratory distress. They can actually get apneic and cyanotic, especially the little ones, because they're getting tired. X-rays usually reveal hyperinflation, so they're not really diagnostic. Okay, you can see air trapping and peribronchial thickening. They may have atelectasis. They sometimes develop large atelectasis. You can see a viral pneumonitis or a streakiness, as they say, but it's really not specific. CBC is usually normal, so the best test to diagnose RSV bronchiolitis or bronchiolitis is to do a nasal pharyngeal wash. That's the best test. And you can do a quick fluorescent antibody, and then you can do it for culture if that's not showing anything. Then you can culture it up. So the best test is going to be nasal pharyngeal washes. The treatment, generally mild cases, you don't need to do anything. A little bit of humidified air is fine, so like a little vaporizer or whatever, but you need to clean those every day. Bronchodilators, typically the recommendations now are you give a trial of bronchodilators. If they work, great. If they don't, you don't need to stay on it. Okay? Some patients with bronchiolitis do have a component of asthma, and they will grow up to become asthmatics. You just don't know who they are. So they may respond to bronchodilators. So you can try beta-2 agonists, but if they don't work after 1 or 2 treatments, you don't need to keep using them anymore. Some centers will give aerosolized epinephrine, like the racemic epis, and it has been helpful in the treatment also. Corticosteroids are not indicated. They really don't have any place. Even though it's called bronchiolitis, steroids have not shown to help in bronchiolitis. Antibiotics are not necessary because it's viral. Okay? If there is a secondary bacterial infection, then they're indicated. When do you hospitalize them? Well, children who are really sick, like this one who's breathing 60 to 80 times a minute, probably needs to be watched in the hospital. His SATs are 92. He needs oxygen. So hospitalization, premature babies, infants less than 3 months of age, generally the peak as they start getting sick, the 3rd, 4th, and 5th days are the worst days of the disease. So if you have a child that's pretty sick at 2 or 3 days of age and you know he's going to get worse, you probably need to put them in the hospital. Patients with chronic lung disease or congenital heart disease, those are patients that may be at risk and a higher risk and should be hospitalized. Anyone with a respiratory rate greater than 60 or a PO2 if you do a blood gas less than 60 on room air. If they're having apneic episodes, absolutely. Many times all they need is to get suctioned out a lot and get all that stuff out. Ribavirin. Ribavirin is an aerosolized agent that can be given. It's an antiviral. It's really not used that much anymore. You can use it for those patients at high risk that we just mentioned. So patients with impending respiratory failure, patients with immunodeficiency, bronchopulmonary dysplasia, those ex-premies, patients with neuromuscular diseases or weakness, or congenital heart disease may benefit from ribavirin, but there's just not really a lot of good studies anymore that show that it helps that much, but it's worth a try on those patients. And sometimes patients will end up on ventilators for however long it takes. Like I said, real little infants can have apneic spells because they get tired or because the secretions just plug them up. Mortality from RSV bronchiolitis is less than 1%, so that's nice. Death can occur from prolonged apneic spells or dehydration because they're not feeding well, because they're breathing so fast, or water loss because they're breathing fast, okay? Or those high-risk infants. Now, there are some babies at risk who receive monoclonal antibody as prevention, okay? And they mention here the RSV immune globulin. That's not used anymore. The IV form is not used. What we used is the palivizumab, which is a monoclonal antibody against RSV, and it's given as an intramuscular injection. It's given once a month during the peak season. The peak season for RSV bronchiolitis is the winter. So they start taking it like in October, November, and keep taking it till about April or May. Once a month, they get an IM injection of this. So these are babies who are less than 2 years of age, and they were like less than 34 weeks gestation, I believe, when they were born and were on ventilators, things like that. They will go and get their monoclonal antibody. Patients with congenital heart disease, however, do not get either form, the IV or the IM form. So remember that. And the differential, number 1 on the list is asthma. And many children who have bronchiolitis will grow up to have asthma. Okay, a 3-year-old white girl presents with a rectal prolapse, and you don't see any worms, like we showed this morning, okay? She's in the less than 5th percentile for her weight and height. The parents also note that she has a foul-smelling, bulky stool each day that floats. Yeesh. They also state that the child has developed a repetitive cough over the last few months. And this is one of the things that you can see on physical exam in a patient with cystic fibrosis, and that is nasal polyps, right there. Okay? Cystic fibrosis is autosomal recessive. You need to know that. And it's on chromosome 7. It is it's a multi-system disease. The old name was pancreatic mucoviscidosis. It's a very descriptive term, okay? But it's not just the pancreas. And it's characterized by these thick secretions just about anywhere, including the lungs. So it's characterized by repetitive pulmonary infections, by airway obstruction, malabsorption, and failure to thrive. It's the most common fatal inherited disease of white children. The incidence is about 1 in 3,500 white live births, 1 in 17,000 black infants in the United States. And actually, even if it's 1 in 3,500, estimates will go to about 1 in 1,600. Okay? And the carrier rate is 1 in 20. Okay, so the carrier rate, 1 in 20 of us in here carry this. So that means that the odds of 2 people finding each other is 1 in 400, and then the odds of having an affected child is 1 in 4. So anywhere from 1 in 1,600 is the incidence, 1 in 1,600 to 1 in 3,500, with 1 in 17,000 in blacks. Okay? That's just simple Mendelian genetics. Okay. What happens? The gene codes for a protein, which is the transmembrane conductance regulator. And when there's a defect in that protein, you get an abnormality of chloride transport. And that produces abnormal mucus. It produces this really thick stuff. Okay? So this stuff will occur in the lungs, gastrointestinal tract, sweat glands, and the GU system. Patients with cystic fibrosis will have an elevated salt content in their sweat and in other secretions, and that's how we're going to make the diagnosis. Okay? They also have difficulty clearing their mucus secretions and get chronic lung infections because they can't cough stuff out. It really depends how it presents. You can present as any child, any newborn that has meconium ileus or meconium plug should be considered to have cystic fibrosis till proven otherwise. Okay? Some babies will present with recurrent upper respiratory infections. Sometimes the parents say he's had a cold forever, and by the way, when I kiss him, he tastes salty. And that's true. That's exactly what they taste salty because of the high chloride content and the salt content in their sweat. Okay? Some patients will present with GI symptoms like malabsorption and failure to thrive. So it really does depend on which organ system is primarily affected to see how they present. Okay? That's a nasal polyp. Some patients, this is a meconium plug, and they actually had to resect a bunch of bowel because it was just stuck in there and not moving. And when it's stuck in there and not moving, you get a microcolon distal to that. And there it is. So there's a patient where there's a meconium plug probably over here, and then distally to the plug, this is a microcolon. Okay? Rectal prolapse. I showed you trichuris earlier, but a rectal prolapse is very common. The other thing that you see in this picture is look at the decreased fat. Okay? Because of the malabsorption in the chronic disease. Another rectal prolapse. Oops, I think that's all the stuff we had for them. Okay. Okay, physical findings that can be you'll see with a patient with cystic fibrosis. Respiratory. Well, they can have an increase in their AP diameter. They can have crackles. They can have wheezing on physical exam. Okay. Meconium ileus. Showed you the picture. Patients with cystic fibrosis will have malabsorption, so they can have chronic diarrhea, and they have these very fatty stools. They also will have problems absorbing the fat-soluble vitamins, A, D, E, K. They can have biliary tract problems, although that's rare. In the pancreas, they can develop diabetes, even though they have an exocrine pancreatic insufficiency. They can also develop endocrine pancreatic insufficiency. There's delayed sexual development. 95% of boys will be sterile. Sweat glands, the sweat test, the salty taste. Okay? These patients, some of them, the ones who exercise and run and stuff, they can sometimes get dehydrated very easily. They need to really drink a lot more fluids. The best test, sounds like an exam question, right? The best test to diagnose is sweat chloride, okay? You can do the genetic test, but it doesn't pick up every mutation. So the best test is going to be the sweat chloride. A sweat chloride greater than 60 is considered positive. And therapy, this is really, you've got to stay on top of these kids. You're going to prevent a lot of complications. They need a lot of calories. You have to attack all these different systems. So patients need to have intensive pulmonary toilet. They need bronchodilators. They need pounding and suctioning and coughing up this stuff. And then when they get older, you'll see them. They cough, 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 and they sound like they're going to cough out a lung, and then they just bring out a little bit of stuff. Okay? But they do that themselves. So intense pulmonary toilet, aggressive management of infections. Most of these patients very quickly get colonized with Pseudomonas or Staph aureus in the lungs or in the airways. So aggressive, and you can, many times it's hard to eliminate it, but you just treat the exacerbation. So aggressive antibiotics, aggressive use of bronchodilators, and pulmonary toilet. They need lots of calories. They need vitamin supplementation with ADEK. They need enzyme supplementation, so we give them pancreatic enzymes so they can absorb better. They need a lot of calories. Okay? Complications, infections, pneumothorax. Okay, they're very prone to have pneumothorax because of the mucus plugging, and then they start to cough and they develop huge pressures and they can have pneumothoraces. So the patient can develop severe chronic lung disease. These patients do get clubbing as opposed to asthmatics. You will see clubbing in a patient with cystic fibrosis. Again, colonization of the respiratory tract. Patients will have worsening pancreatic insufficiency. They can have pancreatitis. And the differential is, since it is huge, because it can be a GI thing, it can be a respiratory thing, it can be an electrolyte thing, so it enters into the differential of many diseases. So you should have a high index of suspicion for cystic fibrosis, and you should do a lot of sweat tests. Most of them will come back normal. That's good. Okay, apnea. A 5-year-old is brought to the physician because her mother states that the child snores and keeps the other family members awake at night. She also stops breathing each night for approximately 20 seconds and then wakes from her sleep. In addition, the mother states that the child is not growing well and has poor school performance. On physical exam, the patient is pleasant and in no apparent distress. Findings include mouth breathing, hyponasal voice, and 4+ tonsils without exudates. So this is a patient that's having probably large adenoids and large tonsils causing this apnea. Apnea, for the most part, though, we worry about it in a smaller child. There's an older child that has obstructive sleep apnea. So that's one of the causes of apnea. The other causes will be in the infant. You get a lot of apneas or the near-miss SIDS and stuff like that. So apnea is the cessation of breathing for greater than 20 seconds. Obstructive sleep apnea will be a combination of prolonged partial upper airway obstruction and intermittent cessation of breathing. Apnea can be what we call central, not from up here, something from up here, or obstructive or mixed. Mixed is the most common form of apnea. Risk factors for apnea. Well, this particular child has big tonsils and big adenoids. Patients with trisomy 21, again, they have big tongue and the airway can be blocked. Patients with cleft palate or just an isolated macroglossia. Remember the one I showed you the very first day with that huge tongue? That can cause apnea. That would be obstructive, not central. Okay, so there's a whole list of things that can cause apnea. And usually the patient with obstructive apnea will have snoring. Obstructive, not central. Obstructive apnea, they can have snoring like this child does. The child may have a history of mouth breathing and may have hyponasal speech and large tonsils with obstruction of the upper airway. Okay, the diagnosis is going to be made by a sleep study, polysomnography, where you look for apneic episodes. So you hook the child up, you look for chest wall movement, you're doing like video EEGs and stuff, and you're looking for apneic episodes. And in this particular case, you take out the tonsils and the adenoids. Complications include poor growth, cor pulmonale from hypoxia, and poor school performance because they get to school and they're sleepy because they didn't sleep very well that night because they kept waking up. Okay? They can die from obstructive sleep apnea. Your differential, well, we talked about central, obstructive, and mixed. So there's apnea of prematurity. So look for a history of a preterm infant, less than 36 weeks gestation. They will have apnea and associated bradycardia. And these patients you treat with caffeine or theophylline. You can intubate them, but then they have to until they get older. But generally, apnea of prematurity is generally treated at home with theophylline or caffeine. Cyanotic breath holding. These are breath holding spells caused by prolonged prolonged expiration, and they can have a cerebral anoxia. Usually they're less than 3 years of age. They hold their breath because of anger. So they have the breath holding spell and they faint. And the treatment is basically reassurance. Okay? And it's kind of hard. You see your child, this is the ones that they say, I'm going to hold my breath till my face turns blue. Well, they cry, and they go, and when they cry, they go, oh, and then all of a sudden you're waiting for them to take a breath. And they either do that or they faint and then you start breathing again. Okay? They can be really spoiled if you're not careful. Because you figure, well, let's not make him angry. Okay. Pallid breath holding. Usually it's after a painful stimulus and the patient will turn pale or white. That's why it's called pallid breath holding. And then asystole and they could have a seizure. And the treatment for them is going to be atropine because of the asystole. Obesity hypoventilation or Prader-Willi syndrome. And I'll show you a picture later of Prader-Willi. It's caused by airway obstruction and it can involve some central control. Prader-Willis tend to be obese and somnolent. They can have polycythemia and cor pulmonale, again from hypoxia. And the treatment for them is hopefully weight loss. Another one now, this was a typical one that's coming up, and the one that comes up frequently. A 2-month-old infant born without any complications via spontaneous vaginal delivery is brought to the emergency center via ambulance with cardiopulmonary resuscitation in progress. According to the mother, the patient was in his usual state of health until 4 a.m. when she found the patient cyanotic and not breathing. What was she doing up at 4 a.m.? Many times the moms have a sixth sense. I'm going to go check on the baby. And they find this. The mother states that at midnight the infant was fed 4 ounces of formula without any difficulty. After the feeding, the child was placed to sleep in the crib. At 4 a.m., she returned to check on the infant and found the child unresponsive. She immediately called EMS and began CPR. The child was pronounced dead on arrival in the emergency department. That's very often, that is the actual story that you will hear. So sudden infant death is an unexplainable death by history or after a thorough autopsy. In infants less than 1 year of age. It is the most common cause of death in infants 1 month to 12 months of age. Less than 1 month of age, they die from prematurity, they die from congenital malformations. But 1 month to 12 months, sudden infant death syndrome is the #1 cause of death. Okay? And there's really no one etiology. There's all kinds of things that are being investigated, okay? But we really don't know. What you do need to know is that the peak incidence, so this is like a classic question, the peak incidence is at around 2 to 3 months of age. The peak time of the year is in the winter time, January, February. The peak time is around midnight to 9 a.m. Okay? There is some relationship with sleep positioning. So that's a hot topic now, sleep positioning. Put the babies on their backs. Okay? Unless they have obvious GE reflux, you put them on their backs when you put them to sleep. Okay? Lack of prenatal care, prematurity, smoking. Okay? Maternal smoking during pregnancy, lower socioeconomic conditions, all of these are risk factors. Okay? But look for the classic presentation that I just gave you, that 2-month-old, wintertime, 12 to 9. Remember that we can put them on their backs to hopefully help. Okay? And there are no studies. There's no one best test. By definition, a SIDS baby is already dead. Okay? So there's no test to diagnose it because we don't know enough. There are what we call acute life-threatening events or near-miss SIDS. Babies will many times have reflux. There may be a cause for this. Sometimes we don't find a cause. Babies can go home on home apnea monitors. It does not prevent the thing from happening. It just tells you that the baby stopped breathing, however. Okay? So remember sleep positioning as the most important thing in prevention. Okay, last but not least, pneumonias. A 3-year-old child presents to the physician with a temperature of 104, tachypnea, and a wet cough. The patient's sibling has similar symptoms. The child attends daycare but has no history of travel or pet exposure. The child has a decreased appetite but is able to take fluids and has good urine output. Immunizations are up to date. Okay, so we have fever, tachypnea, a wet cough. That's a rattly type of cough too. Someone else has similar symptoms, so there's an exposure there. So pneumonia is inflammation of the parenchyma or pulmonary tissue. It is difficult sometimes to tell the difference between viral and bacterial, but there are certain things that we will lean towards, and we'll discuss those. So we can have definitions are pneumonitis, lobar, or bronchopneumonia, depending on the localization. Risk factors, well, infectious agents, viruses, bacteria, fungi, and parasites can cause pneumonias. Aspiration pneumonias, we talked about hydrocarbons yesterday, didn't we? Viral pneumonia is the most common cause of pneumonia in children. Now, generally, children with viral pneumonia don't look as sick as children with bacterial pneumonia. So children with viral pneumonia can have some cough, some wheezing. Bronchiolitis is considered a viral pneumonitis. So they kind of present that way. Some wheezing, some cough, maybe some stridor. You can hear a little bit of crackles, and it's usually diffuse. Patients with bacterial pneumonia have cough, but higher fevers. So this 3-year-old probably has a bacterial pneumonia. Okay? They can have more shortness of breath, more respiratory symptoms with the bacterial pneumonias. And you will hear more localized things like decreased breath sounds over one area as opposed to okay air movement all over with the virals. Okay? So you will look for more localized signs and symptoms in bacterial pneumonia. Always remember percussion. With bacterial pneumonia, since you probably have one area that's consolidated, you will have dullness to percussion on physical exam. Now, there are some patients that have what we call mycoplasma pneumonia or quote-unquote walking pneumonia. They don't look so bad. But when you get an x-ray, it looks terrible. That's probably mycoplasma. Chlamydia. They have a staccato cough. I can't do that one for you, okay? And have a history, maybe a history of an eye discharge. So look for that to think about chlamydia. They usually have low grade or no fever. And in aspiration pneumonia, you usually have a preceding history of something happening. Again, x-rays are helpful. The other thing you need to remember in children is they will not give you that sputum sample. So unless they're intubated, a transtracheal is the best way to get a sputum sample from a child. So that means you have to suction past the vocal cords. That's hard to do. So you're not going to get great cultures from children. On X-ray, a viral pneumonia will show diffuse streakiness, usually bilaterally. Bacterial pneumonias actually show a consolidation, and sometimes in children you will have what's known as a round pneumonia. In adults you see that round thing on chest X-ray, you think of a carcinoma. In children you see that round, it's a pneumonia, like a coin lesion, right? It's a pneumonia. Mycoplasma shows an interstitial pattern in the lower lobes. Chlamydia can show hyperinflation or a ground glass appearance, like when we talked about RDS. And aspiration, it depends. It can be depending on where they aspirated. Bacterial versus viral pneumonia, the CBC is helpful because in bacterial pneumonias, you will see an elevated white count and you will see predominantly neutrophils. Whereas in viral pneumonias, you will usually see a normal white count and it's mostly lymphocytes. Nowadays, we can get nasopharyngeal washes to help us with the viral pneumonias too. So those are some of the things that you can use to help differentiate one from the other. Okay? If you can sometimes get a blood culture that's positive. If you have a pleural effusion and you're tapping it, it's very good to send that for culture too, because that's probably where you're going to find the bug. And again, sputum cultures are difficult to find in children. If you suspect mycoplasma, the best test would be mycoplasma titers. You can do cold agglutinins, but the mycoplasma titers are better. And the treatment will be, for viruses, it's symptomatic, and for bacteria, it's going to be antibiotics. And the most common cause is going to be strep pneumonia, so you can treat appropriately for that. Something about strep pneumonia, which I kind of missed when we talked about meningitis and all. If you suspect strep pneumonia as the cause of severe invasive disease like a meningitis, you start the patient on vancomycin and ceftriaxone. Did I say that yesterday? Today? I'm saying it now. Vancomycin and ceftriaxone until you get your sensitivities back, because there are increasing numbers of strep pneumonia that will be intermediately resistant to the cephalosporins. Okay? And it just reminds me of that boy I told you, the boy that had 58 cells when we did the spinal tap. Okay, true story. All right? 58 cells only. He had streptococcus pneumonia, meningitis, and it was resistant to everything except vancomycin. So you always, if you have something invasive like that, you start them and you suspect strep pneumo, vancomycin and a third-generation cephalosporin. Okay? All right, so again, antibiotics, chlamydia, pneumonia, erythromycin. Group B strep, E. coli or listeria. Again, in a neonate, you suspect pneumonia in that neonate, you're going to start them on something that covers the big three. So you're going to put them on ampicillin and a third generation, or ampicillin and an aminoglycoside. And then strep pneumonia, you're going to treat, penicillin is fine, but you might want to start with something broader until you get sensitivities. Something else, in mycoplasma, you will treat with the macrolides or erythromycin. And something that you need to remember, if you see what they call pneumatoceles on your x-ray, if they describe pneumatoceles on x-ray on the exam, you should be thinking right away of Staph aureus. Pneumatoceles or abscess, think of Staph aureus.